We are really excited to talk to you guys about what you should know in the latest with GLP-1s. Why we're here. Our why really is to inform you all about the space, right? It's a hot topic. I'm sure you've seen celebrities talk about it. You've seen maybe an ad or two about it. I know I can't go to the kitchen table without my family asking about it. I always made the joke that at Thanksgiving, that's the first thing my family asked me when I sat down at the kitchen table was like, hey, what do you think about all of these GLP-1 medications? So it's definitely something that's popular now and will continue to be here in the future. So with that being said, getting into it, kind of what we're going to be talking about today is first, I do want to level set and kind of talk about the clinical background of these medications, right? We discuss a lot of different items and topics regarding these medications, but I think it's important to talk about how these medications will work or how they work, and then some of the side effects we expect to see with these medications. And that'll lead into looking at an analysis of our marketplace dynamics and looking at the book of business trends within employers' health as well to kind of give a realistic view of what we see occurring within this medication class. Additionally, we will explore kind of just utilization trends within this class. I know that's something that continues to be very popular, how long members take these medications, so on and so forth. And we will end with some pipeline considerations as well. Like I said, they're here to stay. They're not going to go away. I will continue talking about them at the kitchen table, friends and family. And so it's really exciting to kind of get to talk to you all today about this topic. With that being said, as promised, going first into that clinical background that we're talking about here, where did we discover GLP-1s? And that really started in the 1970s, where the receptor was first discovered. And then kind of as more research was done, I'm sure, I don't know if you guys are familiar with like the venomous lizard here in the South, the Gila monster. The researcher found that its venom had some of those same properties where that GLP-1 was degraded much slower than that of humans. And so that actually led to the first approval of first GLP-1 on the market, which came in 2005 with Byetta. So Byetta, twice daily injection on a daily basis. 5 years later, looking at Victoza there in 2010, became the first one that was just a once daily, improved efficacy, decreased dosing, and that continued into 2014, where we had our first GLP-1 that was what we know today to be a once weekly injection with Trulicity. That was also the time that we said, hey, the first medication or GLP-1 for weight loss with Saxenda. And I think it's important to note here that with Saxenda and Victoza, those are both the same active compound, the same active ingredient, which is liraglutide. So wanting to just make sure, and that trend that we'll see there is really similar to with the next couple of medications here with Ozempic, Rybelsus, and Wegovy, right? Those are, again, more efficacious GLP-1s that we see on the market, all have the same active ingredient of semaglutide. Important things to note here, obviously, Ozempic is a once daily or a once weekly injection. Rybelsus was actually the first oral GLP-1, so it's the first oral medication that's taken on a daily basis. And then I'm sure we're all aware of Wegovy, our once weekly weight management medication. And that obviously, again, set the groundwork for really some of the other GLP-1/GIP medication that came to the market with recently Mounjaro, and then actually here in December when we had Zepbound hit the pharmacy shelves. So, it's something to note here is that this overall space, there's a lot of GLP-1 medications, there's a lot in the pipeline that Courtney will also discuss. And I want to sort of preface by saying that's actually a good thing. Kind of having all of these GLP-1s on the market, that increases competition overall, lowering the cost of these medications. There was a report that I was looking at so Morgan Stanley in their 2022 report actually predicted that looking at GLP-1 medications for weight loss, by 2025, the net price of these medications would be about $450 net after rebates. And then by 2030, we could expect to see that drop by another $100 to $350 per script, again, net after rebates. So again, it is a positive thing that we see these because they are medications that work great for their indications. And again, seeing that competition, also a positive thing to see. Moving on, right, talking about, well, how do these medications even work? Do you just inject it? There's magic that happens and it goes in, right? No. So it targets 3 different organs, looking at the brain, stomach, and pancreas. So in the brain, it signals certain chemicals to increase or make you feel more full, which is that increased satiety. And so with that feeling, there's less food intake. And even with the food that an individual does intake, within the stomach, there's decreased GI motility and gastric emptying, which is just a fancy way of saying, hey, food is moving a lot slower through the digestive system, food and medications, leading to some of its effects that we see. And then within the pancreas itself, there is an increase to insulin sensitivity and a decrease in glucagon, which is just the body's natural source of producing sugar. I'm sure you guys have all seen a little media post about some of the side effects that we see with these medications, and we will address that here. So some of the notable side effects that we see with these medications, again, kind of go with the stomach, the nervous system, and unsurprisingly, within the respiratory system as well. So the ones we probably are most aware of is within that GI. So that abdominal pain, constipation, diarrhea, nausea, and vomiting, most common amongst the GLP-1 class. As it relates to that nervous system, and increased fatigue or headaches has been noted with these medications. And then, as I mentioned, this is noticed in the adolescent population, more so with the respiratory, so nasopharyngitis, or a fancy way of saying the common cold, was noted within that population. So these are the side effects that we see most commonly within this class. But again, I'd be remiss to not talk about some of the ones you might have seen on a media post somewhere. And that really starts off with the first one that I would talk about is suicidal ideation or increased suicidal thoughts. So that was one that there were reports of it coming out. And again, it generated clicks and a lot of individuals were reading this. And so it actually prompted the FDA to do an investigation into this. And they concluded that investigation here at the beginning of this year in January, where they actually found no evidence that correlated saying, hey, if members taking or individuals taking these GLP-1 medications saw an increased risk of suicidal ideation or those suicidal thoughts. So again, it's just something that when media is putting it out, it's going to generate those clicks. And again, FDA disproved that there was no evidence found between that. And that kind of leads into the other one as well. So gastroparesis is another side effect that has been noted, reported by the media. It's a very fancy way of saying that the muscles in your stomach just stop working. So the food and medications that you take don't digest properly, and obviously that can be quite dangerous if the muscles in your stomach just stop working. Again, with the media wanting to sort of promote and make headlines with their articles, that's one way of doing it. There's really no reports that are saying that, hey, these medications are causing the complete stop of these muscles in your stomach. And that data doesn't support it. So just wanting to level set with two that you might have seen maybe this morning. If you're going through social media, you might have found an article or two about it. So just wanting to address that here today. And with that being said, I think that transitions really well into Courtney talking a little bit about the cost of these anti-diabetic or anti-obesity medications and which ones we have currently on the market.
Absolutely. So I want to talk about the two reasons why we're talking about GLP-1s so much. And it really boils down to costs, like Ernesto was just saying. I mean, it's breaking some of the budgets for our plan sponsors, and it's a big reason why we're talking about it today, but also because of the greater efficacy we're seeing with these newer agents. So if you're looking at the left side of the screen, those are the products that were first approved for type 2 diabetes. The one in green, like Ernesto mentioned earlier, Rybelsus, is the only oral product right now, but actually being studied so it's approved for type 2 diabetes, being studied at higher doses for obesity. And then those on the right-hand side of the screen, those are the medications, some of the more common ones for obesity, and only a couple of them right now are GLP-1s. So the biggest thing was when we consider the launch of Wegovy back in 2021. That's when we finally saw consistent double-digit weight loss for the medications that were approved for weight management or obesity. You know, historically, we were only seeing about 3 to 5% weight loss within these members or patients consistently. So that was the biggest, I would say, driver for, plan sponsors reconsidering coverage for these medications. But then if they add coverage, then we got to talk about the cost impact, of course. So as you can see on the slide here, the medications approved are generally around $1,000 to $1,400 when we're considering the obesity space, so the medications approved for obesity. And when that shakes out to be about $12,000 to $17,000 per patient per year. So again, that's one patient. Of course, that can really break the budgets for our plan sponsors or employers out in the crowd today. So of course, though, when we're thinking of cost within the US healthcare system, I feel like we've talked about it several times already, you have to remember the rebates that are associated. And we don't know drug level rebates, but with competitive market intel, we are projecting that these on the the diabetes side are being rebated at about 55 to 60% of the list price or average cost. And then on the on the obesity side, we're projecting that those are being rebated at about 35%. So I think that really shows what competition can do, like Ernesto was alluding to earlier. So the fact that the diabetes medications are being rebated at a higher percentage, it's because there are more GLP-1s in the market that treat type 2 diabetes, where there's really only a handful right now that are approved for obesity. And we're really talking about Wegovy and now Zepbound that was just approved. It's currently under new to market block with our 2 PBMs. So we'll see that competition here starting. And like Ernesto also alluded to, there's a robust pipeline. So hopefully we'll see that continue to drive down those costs on the obesity side, whether that be list price or increase in rebates to get to that lower net cost and really driving those non-specialty rebate guarantees for US plan sponsors. But now that we started talking about the numbers, want to dive into the market. What are we seeing in the market and what are we seeing within our book of business here at Employers Health? So for starters, we'll look at, and really want to break it down too. I think it's important to distinguish, again, we've mentioned this, but these medications are approved for type 2 diabetes and then different name medications for obesity. I think that gets intermingled quite a bit. So really wanted to distinguish between those here. And first looking at the the diabetes market share. So again, there's several GLP-1s in this space. These are just a few of those that are more heavily utilized. And what are we seeing within the market? And I think it's interesting, talking about Ozempic, all the things that we see on social media, even the Oscars monologue last year talked about Ozempic. We're hearing about it all the time. But back in 2021, Trulicity actually held the greatest market share because that came to market beforehand. But then ever since that, considering Wegovy being approved in 2021, so its sister product on the obesity side, that's when we saw a drastic increase in the market share for Ozempic. And really, if you dive into the actual months, that's when we heard about the drug shortage for Wegovy, we saw an exponential increase in Ozempic. So just goes to show the off-label utilization that has occurred within the last handful of years. And then also Mounjaro, I think, is a big one, as you can see, retaining and gaining some market share here. It was approved in 2022 for obesity or for diabetes. Keep mixing them up. See, I'm saying it's important to distinguish them and can't get it straight. But approved as Mounjaro for type 2 diabetes, its sister product Zepbound for obesity. And we'll continue to see that compete here with Ozempic. But now looking into the data a little bit further, so what are we seeing for the GLP-1s approved in the type 2 diabetes space? What is their comparison? What is their overall cost in consideration with the type 2 diabetes, or the diabetes class in general? So there's several medications that treat diabetes, both on the type 1 and type 2 side. So it's not just GLP-1s. There's things like insulin, metformin, DPP-4s, SGLT2s, GLP-1s. This is becoming an acronym soup here, but just to illustrate that there are several medications. GLP-1s are only one of them. And if we're looking at it from the past few years, back in 2021, GLP-1s were associated with about a third of the anti-diabetic spend within our book of business. Then when we shift to 2022, it was just under 50%. It was about 45% that GLP-1s attributed for that entire diabetic spend. And then now looking at 2023, it has surpassed the 50% threshold and is actually closer to about 60%. So what I'm saying is GLP-1s account for about 60% of the spend in the diabetes space here in 2023. So just something that, again, showing that there, of course, has been off-label utilization, but also want to mention that guidelines are recommending these agents first line for a subset of patients as well. It's not just the off-label utilization. I'm not trying to scare you with this slide, but it is part of it. And we will talk about some utilization management strategies that you can put in place to curb that going forward. Thank you. It says net cost, PMPM. It's net after member cost share is taken out. This does not take into consideration rebates. So thank you. I was going to point that out. So great question. But with that in mind, too, something else I wanted to point out is within the diabetes space, another hot topic is the insulin price cuts, right, that are just happening heavily in the beginning of this year. So what will that do to these PMPMs going forward in 2024? So when we looked at the 2023 data, about $6 of that $35 anti-diabetic spend was attributed by insulins. And if we're considering the average price cut being around 70%, we can see that reduce from, if we're saying that utilization is staying consistent, which we know doesn't happen, but in 2024, if we're looking at that $35, that can reduce to about $30, $31. So again, that's before rebates and rebate credits are taken into consideration, but hopefully some savings there going forward. And now flipping gears here, talking about obesity. So before we do so, wanted to show you what are we seeing in our book of business. Of course, it's still an optional area of coverage. So it shakes out to be about 50-50% for coverage versus exclusion with our clients within 2023. So about 50% excluded, about 50% covered. And of those that covered, so on the left-hand side of the pie chart, 65% of those covered with some sort of utilization management in place. And if you are a plan sponsor or employer and you are considering coverage, that is one area where we would highly recommend utilization management with, to hopefully curb some of the unnecessary and inefficient, ineffective use going forward. So just something to consider here, but diving into the data here a little bit further. So I already did so on the diabetes side, looking now into the obesity side. What are we seeing with the market share? Not shockingly, Wegovy has dominated within the past couple of years since its approval in 2021, just skyrocketed. But one thing I want to point out again is that Zepbound is not on this slide because this was approved at the end of 2023. And with our two PBMs that we work with, it's still on new to market block. So something that will definitely be in competition with Wegovy here going forward. But as you can see, just even within the drug shortages, I think it's interesting. If you look from 2021, even to 2022, when the shortages were the worst, it still had a bit of an incline with the market share because, again, considering the other products on the market that are non-GLP-1s, they just weren't nearly as effective as these GLP-1s that we're seeing today. So now to dive into the PMPMs a little bit further on the obesity side, what are we seeing? So again, looking at this over the last year or so within 2023, and we're comparing the clients that cover with both the market standard criteria, which is 5% weight loss, meaning members would have to show after a certain number of months that they have achieved the 5% weight loss. Where we're comparing it to our custom clinical strategy that we have developed at Employers Health, where we have bumped up that 5% to 10% weight loss threshold. So members will have to show that they achieved that 10% in order to maintain on the medication. And we did so because we really were hoping to drive members both to the more effective medication, so then they can hopefully see better benefit, right? They can see the better weight loss, maybe reduction in risk for other comorbidities, or maybe they stop on their other medications in total, and hopefully minimizing that medical spend for our employers. So overall, generally when we're comparing, and it's kind of small on the screen, so the navy blue or the top line is that market standard 5%, and then the green is our Employers Health clinical strategy for the 10% weight loss. Within the last year, it's been roughly around, on average, 20% reduction in cost with that increased percent weight loss threshold. And now that can be attributed to a couple different things. One is that the percent utilization was a little bit different, a little bit higher in the market standard bucket versus ours. Theirs was 1.3% versus ours of 1.1%. But then also preventing the spend or preventing members that they didn't show the 10%, and then you as a plan sponsor or employer, you don't have to continue covering that if it's not being effective. So again, just curbing that unnecessary spend as best as possible. So then, of course, since cost is a huge talking point with these medications, we wanted to look into a budget impact analysis that was done with IPD analytics. And again, not meant to scare you, but hopefully to give you the tools and show you what we're seeing in the market as well. And they're projecting pretty similar to what we saw in 2023, and that being about $8 per member per month, or roughly around that. And then within the next couple years, as you can see, there's a steady increase. So of course, that has to do with difference in utilization, difference in the amount of eligible utilizers, which are projected to increase a few percentage points each year. So that is why we can see in 2026, it will be roughly around $24. Again, it's just a projection, something to help you maybe project out your budgets. But again, cost we know is a huge aspect of this. And to your point, rebates are not considered. So something just important to consider going forward if you are a plan sponsor thinking of coverage. But
how did IPD pick those eligible patient numbers? I mean, I look at that and I see in 2026 where costs are up super high, that's still only 10% of the people who could get these drugs are on them.
I think so. Yeah, the question was, how did IPD essentially predict the number of eligible utilizers? I think right now it's, we're seeing the rates increase per year for obesity. It's going to be roughly around 50% of Americans are going to be quote unquote ineligible utilizers. So just within the last few years, decade, we've seen that increase a few percentage points each year. So I think that's just what they're utilizing, what we're seeing in the past, and using it. Again, I like how Jeff said, as you are predicting, you can't be wrong. So, but I think that's part of it, just that what we've seen in the last few years increasing each year. Yeah, no, great question. But with that, since I probably just scared you with these numbers, wanted to talk about what are some of the strategies that employers can use.
Yeah, absolutely. So, right, I mean, there are some scary numbers, keeping in mind, obviously, highly rebated products. I think looking into now what we have now in terms of management, we're going to talk about our two vendors that we currently have and kind of how their approach to ensuring that GLP-1 medications are used on label. So looking specifically first at CVS, and looking specifically at type 2 diabetes, they have something called the GLP-1 Smart Logic, which is kind of like a smart PA, which retrospectively looks at claims to see if a member would be eligible or is taking this medication as indicated for type 2 diabetes. And then if they were looking through the claims and there isn't any sort of signs that they are, then it triggers a traditional PA and they go through that process to confirm the diagnosis of diabetes. On the flip side, when we're looking with obesity, the option that we have here in terms of management is really our custom employer's health prior authorization for weight loss. And so we want to ensure that, again, these medications, these weight loss medications are being taken appropriately as the FDA indicated. So looking at that BMI of 30 or 27 with comorbidities. Something important that Courtney actually mentioned a little earlier really has to do with the reauthorization period with our custom edit. And that has to do with the edit that we see with 10% weight loss for continuation of coverage. So that's added in there, again, just because we want to ensure that members that are utilizing these medications, that it's working for them, right? We don't want a member to be on these expensive medications and them not to be losing the appropriate weight and or taking the appropriate steps to make sure that weight stays off. And so just wanting to kind of highlight that in terms of the different management strategies we see within CVS. And then I will hint a little bit into a specific slide that I will be talking about, which really has to do with waste. But here with CVS, there is an option to limit GLP-1s to a 30-day supply. And that's just to kind of help minimize waste, as we will see, and talk about kind of how long members take these medications for, and so on and so forth. So this is switching to our other vendor here with Optum, something relatively similar, but with type 2 diabetes, instead of a retrospective claims analysis, looking at more triggering a traditional PA, where we're just wanting to ensure members are utilizing this medication for type 2 diabetes. On the obesity side, there's sort of two different options that members can elect. Your standard prior authorization follows the sort of same criteria in terms of having that BMI of 30 or 27 with comorbidities. With the risk-managed prior authorization, it's a little different and has a little extra guardrails around it, where the BMI is actually increased to greater than or equal to 35, and it requires the utilization of other anti-diabetic medications that are not GLP-1s to be considered for approval of these medications. And again, as we talk about kind of that waste, Optum also took a step here to, with their early refill threshold, where they increased to try to avoid that stockpiling due to some of the shortages we saw and some of the waste that can be seen if members stop taking these medications. And so with that, that kind of leads us again into our trends in pipeline. And as I kind of hinted with our previous slide, right, like how long do the patients take these medications for? And so we did do an internal analysis last year to kind of to look at just specifically weight loss, GLP-1 medications, to gather a little bit more data of how long they're taking these medications for. And one thing that we saw over that year span, and I want to direct your attention kind of the right-hand side there with the 3 circles, is that there was a 49% discontinuation rate, and then actually 20% discontinued after the first fill of the medication. So whether, maybe it was due to side effects or other reasons that it wasn't working for them, but that's what we found within our analysis. And then kind of along those lines that I talked about, right, with that stockpiling and waste, 5% did discontinue after the first fill and then received a 30-day supply. I want to note that that is a small amount, and then also kind of point your attention to that the majority of the prescriptions were for a month or less. 80% of our prescriptions were for that. So again, kind of indicating that it is a very small amount, and the majority of individuals are filling these medications for just about a month or less. And then I'm sure you may have seen, again, on the internet, some of the studies with the Cleveland Clinic and Prime Therapeutics in terms of how long members are utilizing these medications. On average, we saw about 223 days, or about 7 to 8 months, in terms of how long members were taking these medications. And obviously that does lead to one big question when we're talking about weight loss medications is, hey, they're using for 7 to 8 months. Let's say they lost all the weight they needed to lose to kind of be within that healthy BMI. Are they keeping that weight off? It becomes one of the questions that we like to answer, right? And then, so with this slide here specifically, it's actually looking at Epic. So Epic Research, the electronic health record, they did an internal study as well, looking at well over 20,000 patients to see, hey, after a certain amount of months, were members or the patients, were they keeping the weight off, or were they gaining some of that weight that they had originally lost? And so looking off at the right-hand side in the purple at the very top, and with the, for a darker teal blue there, 44% of patients had some weight regain to complete weight regain. The other 56% had maintained their weight loss and or lost additional weight. So what that tells us is obviously we had a large percentage of patients that did make those modifications, and as soon as they stopped the medication at the 12-month mark, they were able to continue those lifestyle changes to lose additional weight and or maintain it. And with that as well, obviously, if they lose the weight, keep that off, one of the big questions becomes with a medical cost offset, right? And I think that's where we kind of switch in here to have Courtney talk a little bit about that.
Yeah, so I think one of the biggest things too, when we talk about adding coverage for obesity on the pharmacy side, what are we seeing then on the medical side? Are we actually preventing that medical spend, the increase maybe hospitalizations or joint surgeries due to obesity or the comorbidities? And I think we still need more data on that, unfortunately. I don't have the magic 8 ball today. There are studies out there, though. This is one of them that was looking from 2000 to 2010, and what were those medical offsets within these various buckets. So different BMI thresholds, and then also the members or patients in this study, and what percent weight loss did they shed. So the 5% up to the 20%. And this, like I mentioned, was in the early 2000s. So the data we took from it, we extrapolated what that would be in 2024, what that dollar amount would be due to, of course, inflation. So as you can see, the greatest benefit that they found was for those that are at the highest BMI and those that show or experience the greatest amount of weight loss. So on the far right-hand side, that's a best medical or the highest medical offset, which is not super shocking. But I think that does portray the thought that if we are increasing weight loss, if we are offering the benefit on the pharmacy side, there will be some medical offset. Now, will that be within the next 5 months, next year? That's tough to say. I mean, these are things that it probably will be down the road, unfortunately. It might be members that maybe left your plan. So that's something that you have to consider as a plan sponsor. Hopefully we talk about fiduciary reasoning or what we all should be doing, the fiduciary response would be that you would offer this even if the member leaves. You're helping them with their overall health, their holistic care. But it is something to consider that if you're offering this benefit, will you reap the rewards right away just off the dollar set? Maybe not. These are things that it would be down the road, preventing some of that gaining of the additional comorbidities, And again, like I mentioned, maybe the surgeries, those would be things that could be down the road that you're preventing. But again, just something to consider. And also some of the manufacturers like Novo Nordisk with Wegovy had shown that these medications can reduce the risks for cardiac events. So heart attack, strokes, and death due to those events. Now, I will say that's not necessarily real world data. Those are clinical trials, and those were members that were already at an increased risk for cardiac events. So again, just bringing it back to the fact that we still need more information within this area. We need to know more about what will the numbers actually look like for preventing that medical spend in the long run. But just something, oh yes.
Sorry.
Yeah.
Just quick question. On this slide, is this looking at GLP-1 usage for both diabetes and weight loss, or is this just weight loss?
This was just weight loss, I believe.
Okay.
So, yeah.
And then on the previous slide with that graph, how long were patients on a GLP-1 before they qualified to track whether they gained weight or not?
This one was 90 days. So they had to have been prescribed the GLP-1 for 90 days, and then they had to have had a 5-pound weight reduction to be included in this study.
Thank you.
Mm-hmm.
Awesome. Yeah, there's a. Yeah,
Sorry,
yeah.
this one or the
The next one.
the next one? Okay.
So this, like I said, crass. The right-hand side, the purple bar there, that's the 5,000 in savings. That's 5,000 in savings versus $8,000 for the drug, right? So the net's negative.
Yeah, that's something we brought up too when we met with the manufacturer. It's hard, when you're paying up to $17,000, say, for a medication. Essentially, yes.
Okay, I was just,
Yeah. And that's the thing, but then maybe they don't have to take the medication. If they're on a diabetic medication, the GLP-1, maybe they're not taking that going forward. So there's other considerations. Again, that is something we brought up too.
I think about, this is something I struggle with, is it's not just the medical cost of, boy, you give somebody and they lose that much BMI and now they can go walk with their grandkids. Like, that's worth something. And
Yeah.
it's dollars, so it's not just the dollars, but it's hardly captured.
Exactly.
It is,
Yeah.
and definitely being kind of in that early stage, right? We talked about increased competition. So hopefully, right now we talk about that being the offset. I'd like to believe that in the future we kind of would see it, maybe it is a positive number, just simply because, hey, we're looking at the greater competition, lower cost medications for weight management that do work as well. So definitely something also to consider.
And that's a great transition too. For those that didn't hear what he said, there's of course other things that we need to think about with these medications. One thing that he mentioned was, if you lose the weight, maybe it's a grandparent that's able to run around with their grandkid or their daughter or son, whatever. There's other aspects of total care that we need to consider. So thank you for that transition, because we're stepping away now from the direct cost, the dollar bill, the dollar signs with these medications. There's other things that we need to think about, like you mentioned, things like member satisfaction, indirect costs, presenteeism, absenteeism of employees at their workplace. And this was a survey done by Obesity Action Coalition in conjunction with Roe Health, and they surveyed different respondents, and they wanted to see what was their overall appetite for, no pun intended, for obesity coverage. So some staggering results was that about 50% of the members or the respondents, they said that they wanted to work from home because that they felt insecure or that they felt maybe prejudiced at their workplace. And then 51% of respondents said that they would stay at a job that they don't like at all in order to retain obesity coverage. And then the last one that I thought was staggering is that about 44% of their respondents said that they would change jobs in order to gain obesity drug coverage or obesity coverage in general. So I mean, those are staggering to me. If you're employers, I'm not sure if you agree, but if retention is something that is a huge goal or a huge priority for you for the next year, I think things like this are important attributes to consider. You know, what are your employees and members wanting? Will they actually leave the job to get coverage from another employer down the street? Maybe from surveys like this. So, and on top of that, I think it would be remiss to not mention the overall health considerations. So when we're thinking about obesity, of course, it's still an area that's considered an optional area for coverage. But interestingly, since 2013, the AMA, or American Medical Association, has considered obesity a disease. So when we think about diseases, of course, they don't impact everybody just the same. Within this analysis, it was determined that Black Americans and American Indians were at the highest risk for developing obesity. And then in turn, that increased their risk for developing diabetes by 70 to 80%. Another study done by IQVIA found that those that filled these medications, 77% of the members that filled them were females. And then lastly, got to consider the socioeconomic side of this as well. So education levels, employment status, so part-time versus full-time, and then income are huge drivers for increased risk for obesity overall. So just something else to consider aside from the dollar signs that we often talk about with obesity and diabetes. But then lastly, I think we've already teed this up quite a bit, is that this is not going anywhere anytime soon. The pipeline is robust within this area. These are just a few of those that are further along in clinical trials, nowhere near the total of the medications and drug manufacturers that are out there studying these medications. And just a few things that I want to highlight is that there are other indications that they're seeking for, different mechanisms. So there's some like retatrutide that are looking at another hormone as its mechanism. So 3 hormones in that medication. That first one, ribelsis, it actually is an oral. Again, increased doses that are being studied for medications that are already on the market. And then lastly, like I mentioned, different indications, which I think this is maybe the most interesting side of it. There was something that was just released yesterday that they're looking at cardiometabolic indications. So think of things like kidney disease, liver disease. They're also seeking indications for PCOS. And then the most interesting one from my point of view is that they're looking at addiction. So gambling addictions, alcohol addiction, substance abuse. They're looking at that because they found, it's kind of funny when you think about it. You're thinking, of course, they're going to look at anything that they can to get members on these medications. But there is some science behind it because they found that this GLP-1 hormone is attributed to the reward pathway. So kind of like when a member or a patient, somebody is eating something that they love and they get that initial rush of dopamine or serotonin, they found that that is attributed with that reward pathway. And so then they're subsequently looking into gambling addictions, alcohol addictions, and seeing if you can help patients with those as well. But that's early stages, just something that I thought was intriguing that I wanted to let you know about. But with that, we have our last slide, key takeaways. So we've already gone through all of these, again, combining the fact that these are approved for both type 2 diabetes and obesity that impacts a majority of Americans today and a lot of your employees. Something else, of course, we've talked about the costs. So they're about $1,000 to $1,400 per month that will, again, impact the budgets going forward. And again, we mentioned this quite a few times, the utilization management we think is crucial if you are covering or electing to cover, really preventing some of that continued use or continued ineffective use. If members aren't showing that they're seeing benefit, as an employer, no need to continue spending $1,000, $1,400 per month on a medication that's not working. Then lastly, again, the pipeline is robust. These are not going anywhere. We will continue talking about these. But with that, since you all stayed here, we want to thank you so much. So you can look underneath your seat. We all have samples of Ozempic and Wegovy. I couldn't do that legally. I'm very sorry.
Yeah, I
but
think
no.
Zepbound is on this side, actually, and then
that's
Wegovy's
right.
on this side, I believe, so.
Yes. But no, really, we want to thank you. I know it's been a long 2 days of conferencing, networking, so we really appreciate you sticking around and listening to our presentation. We'd love to open it up and see if there's any questions.
You see the discontinuation rate and talked about that in the business. You mentioned the Prime therapeutic thing from like last summer. Is there a difference between Ozempic and Wegovy in discontinuation rate? And I get the doses are different, but I just realized, well, why are people, same drug, why are they discontinuing at a different rate, or are they?
That's a great question. The studies are looking at the obesity medications, so not necessarily diabetes. I will say at Employers Health, we're looking at
That's what I mean. Zepbound's a better case because isn't that the exact same strength and everything as Mounjaro?
Yeah.
So if people are discontinuing Zepbound, but they're not discontinuing Mounjaro, the same drug, what's driving? It can't be the side effects since it's the same thing. That's what I was wondering.
Sure. I think at that point too, our study, we just look at claims analysis, so we don't know the actual member experience, but it could be that maybe the employer doesn't cover or they removed coverage, so the member has to pay for it, and then that's $1,100, $1,400 out of their pocket. Then maybe they can't afford that at the time. Talking about the socioeconomic side, maybe they discontinue. But I will say the side effects.
Not everyone's a Kardashian.
Not everyone's a Kardashian, exactly. So I would say that's another big driver for discontinuation or continuing on obesity medication.
And I think additionally, just from like a clinical standpoint too, it could potentially be a little bit of just a difference with a member who's using it for diabetes and they know I'm trying to manage my diabetes as compared to, not that the weight management isn't important necessarily, but maybe they take a different light on it as a patient where, maybe they have family members who are diabetic and they see certain consequences that occur from not managing their diabetes appropriately. So maybe they're less likely to, maybe discontinue the medication even if they're not feeling great, or having those conversations with their provider of what they can do to kind of better manage that. So there could be, there's obviously a variety of different reasons. That's just kind of from a clinical standpoint, kind of what comes to mind in terms of maybe why there could be a difference, even though not definitive.
Question over here. This could be a question for either both of you or plan sponsors in the room, but seeing the information about how the medical cost benefits are more of a longer time horizon, and we have 50-50 coverage and not covered, how are you all handling patients that come from a plan where anti-obesity medications were covered? Are we still have to leave now, or?
Is that our cue? I'll take a hint.
But yeah, so when they come to your plan and you don't cover it, how do you guys handle those patients? Do you do overrides? Do you just communicate with them that that's not a covered benefit? I guess from your guys' point of view as well, how do we think about that? Would you cover to help prevent some of those longer term effects that they might see now that they're on your plan?
Yeah, I'm not sure if any employers want to take a stab at that, but I would say for the override aspect, we've already heard employers this year that are considering removing coverage because of the great impact on their budgets that they're seeing. I would say a lot of employers, to minimize disruption and allow that benefit to continue. I have seen quite a few overrides. Now, of course, if it's an override, then rebates have to be taken into consideration. If it's an override like that, then you don't get the rebates back on that fill or that member. So, I think at that point, it comes down to the employer's viewpoint, I guess. But I've definitely seen quite a few overrides, even for plan sponsors that don't even cover it in the first place. So, not sure if any client disagrees or has anything else, but.
I would just say that if an employer doesn't cover weight loss medications and a participant comes to its plan, it will probably not cover the medication, making an exception, especially in light of what we heard, Jeff talk about the J&J lawsuit and prudent use of funds and the plan funds. To make an exception to pay for that, you might run into some challenges there.
Absolutely. That's I would say on the rare side, the overrides for those that don't cover in the first place, especially when you consider member word of mouth. If you make an exception for one,
yeah.
then you have to make an exception for all. So there's a lot to think about for sure.
Hey, Courtney and Ernesto. Just wondering if you guys are able to at all identify who maybe the typical or average utilizer of some of these products are based on, various sort of demographic or clinical characteristics, BMI, age, things like that, males, females. Who's utilizing these? If you guys have been able to uncover that at all in your data.
Yeah, I think so. Kind of mentioning your IQVIA report. So with IQVIA, they actually mentioned it was almost 80%. It was 70, I think 77% were women, and it was between the ages of 40 to 55. So middle-aged women are usually the ones that are utilizing these medications, weight loss medications, the most. And that was just based obviously on the international report. So from that perspective, that's who is utilizing those medications. From an internal analysis, I don't think we haven't taken a look into that, but that tends to be the population that maybe is more tech savvy, maybe seeing more of the media ads and all of that, as opposed to, or maybe takes more care, is more health conscientious, as opposed to maybe a male. I know as a male sometimes I put stuff off, so I don't know if that has anything to do with it.
Thank you. Yeah, and then if I can, just another unrelated question to that. So with the 10% threshold and then the risk managed approach with BMI, the higher BMI threshold, do you guys notice any sort of pushback or friction with providers or members? It makes sense clinically, but I'm just wondering if you guys kind of get sort of in line with the first question, get heat around, well, why isn't this covered in maybe a 30 to 35 BMI, or if I lose 8%, why can't I stay on it? Have you guys heard of that at all?
I would say, just anecdotally for my clients, there's definitely some members that will come back to the HR folks and ask why. There is not as much noise as I was expecting, to be completely honest. There definitely, and then considering the clients that cover with the PA, maybe that 5% and then increase to 10%, that's when I think I hear the most noise from members because of that change. Of course, change is never fun, so that's when I think you hear it the most. But if it's right out the gate, maybe a client didn't cover, put the open up coverage, prior authorization with the 10% weight loss threshold, I haven't heard much noise from that at all, which I was quite shocked about, to be honest.
What do you have a denial rate for your people that meet that threshold, that 10%? What does that look like for you guys? People that are losing 8% versus 10?
We have the initial prior authorization approval rates, which the criteria for getting on the drugs, 10%, 5%, it's exactly the same. So we have that initial prior authorization approval rate, which is around 70%, where we're going to see the difference. So it's pretty much the same. But where we see the difference is down the road. So the reauthorization, and we don't have that criteria yet.
And that's what I wonder. Maybe you don't have any noise because there aren't any people that are doing that. They're either losing 15% or they're stopping the drug anyway.
Sure, yeah. But of course, it's not going to work in everyone. But I agree. These medications are showing more than that 10% consistently. So I agree. The majority of patients are seeing that. Maybe that's why we don't hear the noise. That's a great point. Oh, another one.
Oh yeah, yeah, another, one of my favorite topics. Has there been any discussion that you've seen around, as we think about the pipeline, going down the road, more and more products entering the marketplace, how employers or plans may treat individuals that are trying this again, right? So maybe they tried one of the early GLP-1s, maybe they were one of the 50% that discontinued. Are there going to be plan restrictions in place in terms of whether they can try again or whether they can try a new product in the future?
Yeah, I think we have looked at duration of therapy limits. So that would be a class effect. So if they've tried a medication, a GLP-1, what we've looked at is maybe 3 years in total that a member could take a GLP-1. Maybe they started on a different one. They would have a total of 3 years that they can take a GLP-1, whether it's changing or going back on the same one, whatever they choose to do. But that's not across the board. That's just something that a plan sponsor could do. They could elect to put that duration of therapy limit in place to prevent some exorbitant spend, but we're not seeing that across the board by any means. It's something we're looking at going forward.
And do you think that the utilization will increase in the future with the introduction of oral products for the weight loss designation?
I think potentially, I'm not necessarily sure that there'd be a whole lot of, or I'm not entirely sure how many patients we could see that saying, hey, I don't like giving myself a once weekly injection, would prefer to take an oral medication. But I'm sure there are some patients that they do feel that way, that maybe they don't like the injections or afraid of needles. It freaks them out. So I could see there being a subset of population that would be more willing to try, an oral product that is a study that actually does work. There's a great weight loss, and they don't have to inject themselves on a weekly basis. So I could see, I wouldn't be able to give you a percent what I believe that would look like, but I definitely think there will be some patients that want to try them.